start now Roche Symposium about dual blockage in early breast cancer case. We are now in Roche Symposium about dual blockage in early breast cancer. It's an honor to me to welcome chairperson. سعيد جدا ان يكون معايا استاذتي دكتور هبه الظاهري. She shared our history in our unit. We have 50 years of practice in our department. دكتور هبه ناقشتني من 20 سنه في الام دي بتاعتي. هي كانت الاكزامر بتاعتي. Very proud to be with her, with our eminent professors. Dr. Ahmed Sliman, he will share with me the case I presented today about early breast cancer. Professor Dr. Ahmed Jamal, one of the eminent professor in breast surgery in our MDT unit, and with attendance with Dr. Tawab, the pioneer in our MDT over about 11 years of practice. I will talk today about dual blockage in the early breast cancer cases. What's the rule and what's next?
طلبوا نستنى 5 دقائق في حضور اقوى.
Waiting for attendance. الناس كلها واقفين بره في اللونج.
انا يعني يسمحوا لي.
It will be a long day with breast cancer. Starting from now till 2 hours, we have a symposium and teacher modules for the younger colleagues.
Okay, so before anybody starts, I would like to extend my thanks to the all organizer of this scientific conference. And as mentioned before, I consider myself one of the senior professor in the Symposium University. على فكرة يا جماعة يعني مش هضيع وقت، أنا والدي الأستاذ الدكتور محمد ربيع الظاهري كان أستاذ فارماكولوجي في عين شمس، لكن الناس دايما مستغربة إحنا ليه ولاده ما دخلناش عين شمس ودخلنا القاهرة، ولكن ممكن ده يكون في أيام الدكتور صلاح عبد التواب، ولكن قد يكون إن إحنا كنا ساكنين في المعادي فكان يعني اختيار جغرافي أسهل. فأنا من زمان جامعة عين شمس تمثل بالنسبة لي الجامعة العريقة التي عمل فيها والدي، وكان الحمد لله محبوب، ويعني الحمد لله هو افتتح قسم الفارماكولوجي في بحوث مركز البحوث، كان أول واحد يطبق الهيربال ميديسين and the natural medicine في كل الديزيز. احنا النهارده سعداء جدا في وجود الاستاذ الدكتور احمد جميل، الدكتور احمد جمال والدكتور احمد سليمان، وفي وجود الدكتور محمد صبري القاضي. طبعا he is a known professor and my student as well. As long as we are in Roche, we like to thank Roche. But when you hear about landscape of HER2 positive, this is very good title and it will cover many things. بس هقول لكم حاجه برضو عشان افتح نفسكم قبل ما الدكتور صبري يتكلم. كل ما الديزيز يبقى فيه ستاندرد اوف كير سيتلد لاندسكيب خافوا، هتتبسطوا بس خافوا. This is usually bring us in a problem of what if those standard patients who take a proper care not respond well. This will give you some problem in practice. So دكتور محمد أنا مش عايزة أضيع الوقت أكتر من كده، حضرتك اتفضل deliver your presentation.
Thank you, Chairperson. I will talk about today about the dual blockage in focus in early breast cancer case. عايز أفكركم دي كانت آخر سلايد لينا السنة اللي فاتت. We were celebrating the FESGO, a new member in HER2 family in our department. We started 1 year ago to give FESGO for our patients for the new adjuvant setting and adjuvant setting, and also TDM1 is one an era in our department. No reconstitution, no dilution, no IV loading dose, no IV injection. We are treating 100 patients with dual blockade subcutaneously with improving quality of life and saving time and hospital admission. That's why it's my disclaimer. Firstly, we will describe how big the problem in breast cancer in Egypt. We have now the same incidence as worldwide, but we have 1.6 double mortality more than worldwide. That's why we should qualify our practice in HER2-positive breast cancer and all other disease in breast cancer. So we have HER2-positive represent about 20 to 25% of younger population, usually younger females. They presented with local advances or metastatic disease. They curable if they presented without M1 disease. And also, we can remind yourself that you have 12 years follow-up after HER trial. In this trial, we have now 12 years after finishing with HER trial with the main goal of single blockage to have longer disease survival and overall survival. And then we move to the neoadjuvant setting to give dual blockage in the patient with nodal positive disease or T3 disease to have a PCR, complete pathological response, which dominating the improving on overall survival and disease-free survival. That's why the fact PCR now post-neoadjuvant correlate with improved disease survival and overall survival. That was in the Codzar meta-analysis about 10 years ago. They highlighted that any patient with HER2-positive disease or triple-negative disease should receive neoadjuvant treatment before surgery if she has T2 disease or nodal positive. In this meta-analysis, about 61% of the patients were T2 and 46% were nodal positive disease. And there's significant correlation between pathological complete response and improving of PFS and OS survival for those patients either HER2-positive or triple-negative disease. That's why this meta-analysis that in the HER2-positive disease, the benefit is there for the neoadjuvant treatment. Disregarding the hormonal status, either ER-positive or ER-negative, the benefit of dual blockage in the breast cancer, T2 and nodal positive, is there for the neoadjuvant setting, disregarding the hormonal status of the patient. So in the old guidelines, that's intermediate, high risk, early breast cancer, triple-negative or HER2-positive, it's no longer an option. It's an ethical obligation to give a neoadjuvant treatment before surgery. And actually, we recognize this in our MDT meeting. We captured many cases in early stage breast cancer and treating there by neoadjuvant dual blockage or even single blockage. And we have very successful stories with our patients in MDT and in Shamsi University. That's why dual blockage by adding pertuzumab now plus pertuzumab is a standard of care for patients with T2 more than 2 centimeters or 2 centimeters or nodal positive disease in breast cancer high-risk patients. So we have 3 main trials. We have an USP trial, we have Tarantino trial, we have Bernice trial. They are proving adding of pertuzumab to have a benefit in the nodal positive disease. Smaller tumors, T1A, T1B, or nodal negative, they eligible to go upfront surgery. But patients with T2 disease, more than 2 centimeters or equal to 2 centimeters, or nodal positive, they allowed to receive a neoadjuvant dual blockage as standard of care. So we have a new series trial. The new series trial highlighted the role of pertuzumab because in this trial we have 4 arms of treatments. The most important 2 arms are the upfront 2 arms to give pertuzumab plus trastuzumab plus docetaxel, or to give it alone with single blockage. And we found that adding of pertuzumab doubled the pathological complete response from 29% for single blockage to 40% for the adding of pertuzumab to the chemotherapy in the neoadjuvant setting. Followed by the Tarantino trial, who highlighted how many cycles is enough to have an optimal PCR and which chemotherapy doublets can be given with the dual blockage. And if we can found that the patient with TCHP plus dual blockage for 6 cycles having the highest pathological complete response, about 80% of patients. It's a very high number of PCR we use DCHP plus dual blockage either for ER negative or PR positive tumors. Then the Pernice trial, it is a less important trial because highlighting the most safety of giving anti-HER2 plus trastuzumab in sequencing after either dose dense AC or PEG regimen. So by the collection of the data from these main three trials, we have the SPEED trial, the Pernice trial, Taratina trial, they are proving the role of pertuzumab plus trastuzumab plus chemotherapy as standard of care for the nodal post disease and larger tumors. So nowadays, for guidelines, NCN or European or ESMO or even NICE guidelines, we are totally recommending to give dual blockage plus chemotherapy for the nodal post disease. So the next question is neoadjuvant setting dual blockage plus chemotherapy only is achieving PCR is enough? The answer is no. Still, in the NUSIL trial, at 5 years follow-up, we have 14% of patients relapsed or died, and risk of recurrence still remaining even after 5 years of recurrence. That may be that HER2 nowadays may be along some patients have late relapser as ER/PR positive tumors. So, pertuzumab in adjuvant setting, in the we have now 8 years about after the Affinity trial. Affinity trial started pertuzumab in the adjuvant setting plus trastuzumab. They didn't give neoadjuvant, but gave it in the neoadjuvant setting pertuzumab plus trastuzumab, and we have now 8.5 years of post-Affinity trial. The answer question is it HER2 positive, is late relapse disease or not? We found that the patient receiving adjuvant setting pertuzumab plus trastuzumab plus chemotherapy and continued dual blockage for 1 year, they have still achievement, especially for the nodal post disease, they are still achieving more better disease survival. Although the absolute benefit in this trial is 5%, but still the curve still separating between the patient receiving dual blockage versus patient receiving single blockage. From this trial that we are achieving late or delayed event disease survival by adding pertuzumab to trastuzumab for 1 year for the nodal post disease. In the nodal negative disease, the two curves are overlapping. There is no benefit of pertuzumab in the patient with nodal negative disease. Although the benefit also is there for the patient receiving dual blockage, either ER positive or ER negative disease. So the next question is dual blockage in adjuvant setting in all patients enough? The answer is no. Still, we need more care for the patient didn't achieve pathological complete response. We have a Catherine trial published in 2018. We have this design of giving a dual blockage or single blockage plus chemotherapy for the patient, and there's randomization to receive PD-1 or trastuzumab a single blockage, and we have now 50% reduction in the recurrence after 3 years of follow-up for the patient receiving PD-1 as an adjuvant treatment for the patient who didn't achieve pathological complete response. And also, the benefit is there. You have in this trial, we have a two population of disease. We have in the neoadjuvant setting, 80% of patients receiving trastuzumab plus chemotherapy as a single blockage, and 20% receiving dual blockage plus chemotherapy. Both subgroups are gain benefit from adding PD-1 for the non-responder, non-complete responder patients. We have 11.8% improvement, absolute benefit for the patient receiving a single blockage in the adjuvant when you give PD-1 post-operatively, or dual blockage in the neoadjuvant setting. There are 10%, 10.5% absolute benefit for the patient receiving PD-1 post-neoadjuvant dual blockage. So I present this case with my colleague, Dr. Ahmed Suleiman, Professor of Radiology, because we have now the pathological complete response is a predictive marker for anti-HER2 treatment post-operatively. This case is 33 lady, left breast cancer, left upper inner quadrant, lateral lymph nodes, and I want Dr. Ahmed to continue this case.
33 years old lady presented with left breast upper outer quadrant mass showing typical features on sonomammography, ill-defined speculated mass, having same appearance on the ultrasound. Through cup biopsy, multiple cores were taken, and histopathology revealed invasive duct carcinoma, grade 3, ER/PR negative, and HER2 positive. Among the given data, the patient was staged as T2 and 2M0. The patient was referred from Dr. Al to be clipped. Clip was in the center of the mass, and you can see the clip within the center of the mass on the ultrasound and the mammography. And Dr. Al was asked for MRI. We can see over here the mass showing avid enhancement and diffusion restriction on the left side. And we found the internal mammary avidly enhancing lymph node along the internal mammary chain. Fourth cath was placed in order to start chemotherapy plus the dual blockade according to the protocol. And Dr. Sabri suggested if it's possible to take a biopsy from the internal mammary lymph node for optimum staging before neoadjuvant therapy. We revised the contrast-enhanced CT scans of the patient in order to avoid any blood vessel in the field, and the level of the enhanced internal mammary lymph node without the contrast-enhanced CT scan. So, left parasternal approach was chosen at the point of entrance with advancing the biopsy needle, few millimeters, and then CT scan, then few millimeters extra, and then CT scan because it's in a very injurious position, till tissue biopsy and histopathology with us confirmed that the nodule has metastatic deposit. Chemotherapy was taken, and the patient finished the neoadjuvant till complete radiological response. We no more can see the mass, we just see the tip within the same location without any massing. However, on PET-CT, we can still see that the internal mammary lymph node is enhancing, and to a lesser extent, the left breast upper outer quadrant mass. So, Dr. Adi told me, can we take a biopsy again from the internal mammary lymph node? Another trial of having, but this time it was a fine needle, and I had a pathologist with me, a colleague of mine, and he confirmed by fine needle that it's metastasizing lymph node, still showing residual disease.
Thank you, Dr. Ahmed, about your elegant work. You can see here that radiology plays a role of surgery because the internal mammary lymph node is not excisable lymph node. You should stage before going to surgery because the surgeon will not remove this lymph node. The faint uptake should be specified either to be pathologically responded or not, because it will be determined how to give the treatment or what to give the treatment after surgery. Because this patient, when going to surgery, she had complete physical response to the tumor mass and the axillary lymph node. But still remaining, the internal mammary chain should be identified pathologically. That's why the radiology here plays a role of surgery to have a biopsy from this mass, and unfortunately, the patient have still nodal pocket in the internal mammary chain. That's why she will receive TDM1 instead of dual blockage after surgery. That's why I highlighted the MDT work in our session, in our meet MDT, because the role of MDT is very important to make a communication with your colleagues, to have accurate defining of the best, especially we are the pathology to determine your choice in the treatment. So the patients highlighted to give PD-1 as an adjuvant treatment after doing the pathology and to have residual disease in the intermammary chain, and actually this chain will be involved in the radiation field to have a more response after treatment. So we have now in these guidelines the PD-1 is still in the guidelines in the upfront use from ESMO. DXD may be have a role in the adjuvant setting, but not yet highlighted. This is the algorithm of how to treat the patient, how to de-escalate or escalate tumor. Tumor cells more than 2 centimeters have a dual blockage or nodal positive, should have a dual blockage, then surgery. The patient have no PCR, should receive PD-1, and maybe Neratin for extended for the patient with bulky disease after surgery. Patients achieving PCR either nodal negative, you can go for single blockage, or nodal positive should receive dual blockage after surgery. And the patients with low risk as T1 and 0 may go for surgery and followed by dual blockage or single blockage according to scope. Thank you. The conclusion: T1 0 primary surgery is feasible for tumor confirmed to be early disease, but T1 T2 disease 2 centimeters or more or nodal positive disease neoadjuvant. Chemotherapy plus dual blockage is standard of care disregarding ER status. High PCR rate 80%. For the difficulty is recommending to go for THP for younger patients. We are negative patients with nodal positive disease to be the optimal sequencing as Latino trial. Adjuvant and tier 2 plus chemotherapy backbone and anthracycline maybe go for our situation because many patients delayed for approving and tier 2. So you can go for AC followed by taxane plus dual blockage. And nodal positive disease should have a dual blockage as a clinical trial. No PCR should go for PD-1 in the adjuvant setting. Thank you.
Thank you, Dr. Muhammad, for your marvelous presentation as usual. Thanks to Ahmed Suleiman. The presentation emphasized the importance of MDT. Simply, I think that we are not reaching this approach without MDT. The key of success is discussion with each other and discussion with the patient. Now, is there any questions from the floor?
Thank you very much, Dr. Muhammad. I can share with the surgeon, great Professor Ahmed, what is the maximum centimeter you don't like to give neoadjuvant in the head field? If you have a young patient, node negative, tumor size, breast tissue, tell me about your practice.
Throughout the web.
For the cases like this, literally 2 centimeters, T1, not more than T1. I will send that to our colleagues for 3 centimeters, 4 centimeters, T2 as the stability test. With the positive, of course, we'll go for neoadjuvant.
سؤالي ايه امتى يكون discussion بين حضرتك وبيننا ان please this for surgery although she is HER2 positive وانا بقول according to guideline I'd like to have, because I'm telling this because nowadays very recent literature about the disadvantage of the neoadjuvant. الدكتور محمد صبري القاضي يوضح ان 80% من العيانين اللي هم according to neosphere trial will go in pathological CR. العالم كله بيبص طب وال 20% هل انا اخرتهم؟ And this is a disadvantage. I mean I am طبعا believer, انا من زمان supporter للنيو adjuvant. I don't like to change my skin, but really we have in Egypt some patients that they have a very large breast and small tumor. انا ما بقولش اكتر من 2 سم يا فندم، انا بقول لحضرتك انت كجراح امتى تقول بلاش يا جماعه دي تستفيد اكتر بالجراحه، ولا انتوا خلاص convinced بالهيرتو انه لما
دكتورة هبة, let me answer after Dr. Rida about the surgery. Because we have a scenario of the cases because we have not same family of HER2. We have a younger patient, grade 3 tumor, even with tumors less than 2 centimeters. We have a case scenario if we found that younger patient ER negative tumors, HER2 positive, grade 3 disease, and have a tumor size of 1.5. These by guidelines with nodal negative. These by trial design of Nusfir Utrafina didn't receive any Q1A to Q1B, not Q1C. Maybe go for surgery. But in real practice, the need for a chemotherapy with dual blockage to have an optimal response because the subgroup population in the Utrafina trial, the patient getting 80% PCR are the patient with ER negative subpopulation. On the other hand, was elderly patients having tumor size 1.5, strongly RPR positive. She has grade 1 to 2 disease. You can go for surgery upfrontly because this case is have no more time to have 10-year survival to follow up in the dual blockage. So I think the HER2 positive in the community of these, we can make the patient eligible for neoadjuvant setting or patient to go for upfront surgery. Adding for this, the Fergan trial now in ESMO, they published some patients may have early responder but do a PET-CT 2 weeks after neoadjuvant. It's a very high technique PET-CT in imaging to have an early assessment for patients with having a very rapid response by PET just before treatment and 2 weeks after dual blockage. Those patients may be eligible to have hormonal plus anti-2, but not now because there is a lot of concern about response rate. It is PCR about 40%, half of the optimal response getting by PCHP. So I think Dr. Rida share with me his experience about the scenario of this.
I have a question to
دكتور رضا، بس انا بعد ذلك انا هانصر على الحته اللي الدكتوره هبه قالتها. يعني احنا دلوقتي في البراكتس بتاعنا في الام دي تي في عين شمس، وانا بالنسبه لي بروح كمان اماكن اخرى، يعني احنا بقينا ستيكي جدا. تي 1 سي، انا بقول تي 2 بقى، انا بتكلم على اكتر من 1 سم 1.2 1.3. انا جو فور كليبنج نيو ارتن هيرت نيو وفي تريبل نيجاتيف، وبنحط العيانين اندر كومبليت سوبرفيجن. هم ما بيسيبوش العيان، حصل توكسيستي حصل اي حاجه ريفيرال على طول، الدنيا كبرت ريفيرال على طول، تمام، لان العيانه محطوطه في سيركل خلاص اندر فوكس. بس انا وجهه نظري انا ما اقدرش ان انا اسكيب البي سي ار اللي ممكن يديهولي، وما اقدرش اسكيب برضو النولج اللي هي ما جابتش بي سي ار. ما دي نولج، دي انفو انا عاوزها، اللي هي ممكن اعملها شيفت لكابسايلا او كده. فانا من اول تي 1 سي ان 0 بريفير لانكولوجي، ده حاليا شغالين كده.
انا سعيده جدا لاني باكثر من 10 سنين كان نفسي اسمع الجراحين ان هم to that believe of neoadjuvant and detail of biology.
دكتور هبه،
عند البرزنتيشن الحاله this had positive note in the axilla.
Yes.
And you got complete pathological response.
No,
regard the mass and the axilla. There is tendency now for de-escalation of axillary surgery. As surgeons, we would prefer to do something like targeted axillary dissection in this case. So why you didn't put a clip in the lymph node to allow us to do, while we did clearance in the axilla, we could maybe...
Very good question, because the patient was presented with nodal positive N2 disease, which have multiple subvector lymph nodes and more than 6 lymph nodes in the axilla. That's why we didn't put clips in all of these lymph. She presented with heavily studied axillary lymph node. And actually, the response of these lymph nodes was marvelous after third cycle. But actually, when a patient presented with us with internal mammary chain and liver on level 2 lymph node, we can in the real practice put many clips in the axilla, although the response pathologically very important for node restation, but actually she had a complete radiological response after DO blockage and ECHP, and we have just remaining the internal memory chain ipsilateral to be a faint uptake. That's why the challenge is to take the biopsy from this. And actually, one of the secondary endpoints in the Trafina trial and the T trial is to de-escalate the dissection and make optimal very dissection for the patient, but this is the secondary point, not the primary as PCR. But a very important issue to have de-escalation of surgery and also a very good dissection after the blockage in the neoadjuvant setting.
يشرفنا وجود الاستاذ الدكتور تامر النحاس. اتفضل.
Dr. Heba, thank you very much. You have highlighted a very tricky situation, which is the cutoff between the neoadjuvant and the upfront surgery. It's always a discussion. And let us confess, all of us, that there is some T1C requiring neoadjuvant and some early T2 not requiring neoadjuvant. So the question here is that when it comes with a surprise with the T1C, when the pathology comes with a positive sentinel, and sometimes you're upset that an early T2 went for an upfront surgery and it come out with a node negative axilla, and you're very happy because here you don't need all this intensification. And Toleni protocol, 12 weeks of Herceptin Taxol is completely curative with an event-free survival reaching 95% at 5 years. So there is still some early T2 with node negative, and there is still some late T1C with node positive that you cannot know except in the sentinel. This area is extremely gray, and it needs a bit of magnification for our thought to know where is the exact cutoff. But it's still arbitrary in this area. Thank you very much for highlighting that.
Thank you, Dr. Tan. Actually, we have a lot of questions and lots of debate because it's a breast and because it's a hair too.
دكتور علاء انديل.
اتفضل دكتور علاء.
دي بروفيسور.
لا اتفضل استاذ دكتور علاء انديل. اتفضل. انا اسفه.
Thank you so much for this excellent discussion. But I do believe that understanding the biology, HER2 patients do need neoadjuvant therapy, because as زي ما حضرتك تفضلت يعني it's the knowledge of the biology of the tumor rather than the surgery. I mean, we can remove any type of tumor. I mean, even if the tumor is 5 centimeters, he can go for surgery and remove it. If the patient is having a large breast, you can go for surface surgery. But the thing is that you would like to know what is that type of tumor. Is it responding or not responding? And what Dr. Tamer mentioned is only between what type of anti-HER2 therapy you will be applying, either a single agent with paclitaxel but no matter what, neoadjuvant therapy will give you a very important piece of information. It's not the size, because surgeons can remove tumors up to 4 or 5 centimeters. It's no big deal. But the principle is the biology. I mean, it's not acceptable. After knowing the biology, we come back to do surgery to start with. It's not acceptable. Thank you.
I agree too much with this. Thank you very much for attendance. Thank you, Dr. Mohammed Sabri Al-Abi. Thank you, my co-chairperson. And now we close the Roche Symposium and go to the scientific session of breast cancer.